Okay, so yesterday we left off talking about sinus bradycardia, and so this is just another example, another strip of sinus bradycardia. So we can see that this is a 6-second strip here. If you count the big boxes, there are 15 big boxes between each of those hash marks. Why did this not get big? Sorry about that. I thought I made, there we go. How about that? That's a little better, huh? So if you count between those hash marks, you would count 15 large boxes between each of those hash marks. And we know each one of those big boxes, again, is 0.20. So if you did the math and calculated it out, you would figure that out to be 3 seconds. And then we have 15 big boxes again from the second hash mark to the last hash mark. And so we have a 6-second strip here, and we could calculate this out using those methods that we talked about yesterday and find out what our rate is. Now, because it's a 6-second strip, I know the quickest, easiest method for me as a nurse is to take how many QRS complexes I have on the 6-second strip and multiply it by 10. So I have a rate of approximately 30, okay? So that was just another example to show you. See how this strip is not as pretty as those initial ones that I showed you early in the lecture? They're not all going to be beautiful, but you can clearly still see that there is a P wave, here is a QRS, and here is my T, okay? It's just very slow. Okay, so now we're going to go into, excuse me, sinus tachycardia. Okay, yesterday was sinus bradycardia. It was slow. Today is sinus tachycardia. So the last name, again, the first name is sinus. So again, oh, some people must have got booted out. I got to bring them back in from the waiting room here. Hold on a second. Sorry, guys. Okay, Sierra. Okay, everybody should be back in now. Okay, so the first name again is sinus. So you're going to see again the upright, nice rounded P waves. Our PR interval is going to be normal, 0.12 to 0.20. Our P to Ps and our Rs to Rs are going to be regular. Our normal QRS. The difference here is that the last name of this is tachycardia. So we know that the rate is going to be greater than 100 because we know that normal sinus rhythm is 60 to 100. So if we're faster, if our last name is tachycardia, we're going to be greater than 100. That's it. Don't overthink it. Okay? Okay, come on, computer. There we go. All right. I guess it's having trouble waking up. So again, some things you can read here on your slide, some causes and some treatments. Again, figure out the reason for the tachycardia. If the patient is asymptomatic, we're not going to do any kind of treatment. We're going to continue to monitor. If they are symptomatic, you see the things here on the slide that you might do. You may see sinus tachycardia if the patient is going through alcohol withdrawal or if they are currently intoxicated. So that's a possibility. But again, if they're asymptomatic, we're just going to continue to monitor. Here's an example of that. I have a 6-second strip here. Again, even if I didn't have the hash marks, I could count out 15 large blocks, and I would know that that is 3 seconds, again, because you can do the math, the 0.20 for each one of those big blocks and figure out your math. Okay, but I have a 6-second strip here. It's marked out for me, so I can count how many QRS complexes I have here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. It's hidden behind my Zoom screen here. Let me count that again. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 QRS complexes. So what would my rate be?
130.
Correct. Correct. But you see here, my P looks pretty normal. It's upright, it's rounded. My QRS looks pretty normal. I can actually even see a little bit of the negative deflection for the start of the Q. We don't always get to see that. my R, my S, and nice rounded upright T wave. So it all looks normal. It's just fast. That's it. Make sense? Here's another one. This one's a little bit hard to see, I think, because the lines tend to blur, at least with my aging eyes. But you can count this out. Here's a hash mark. Here's a hash mark. We don't have one on this end, but we could count back just to see how far it is. Make sure it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Okay, so there should be a hash mark here. They just omitted it for whatever reason on this drawing. So I have a 6-second strip from here to here. So let's count it out. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, because I'm going to stop here. So what's my rate?
120.
120, exactly. Again, beautiful, round, upright P waves, QRS, and a nice, beautiful, upright and rounded T. They're not always going to be this beautiful in sinus tach, but you still should be able to identify your P, your QRS, and your T, because again, it's all normal. It would measure out normally, your P to P, your R to R, everything's going to measure normal. It's just going to be fast. So if I measured this PR complex and this PR complex and this PR and this PR and all my QRSs, they're all going to measure within the range that they're supposed to be. Just fast. All right. Now, yesterday when we very first started, I talked about arrhythmia and dysrhythmia, and I said a lot of times you're going to hear those used interchangeably. But really, dysrhythmia means that there's something not normal, and arrhythmia really means that there's just an absence or a pause. And so we're going to take a peek real quick here at sinus arrhythmia. So it starts in the SA node, but the impulses are not regular. Your P to P and your R to R are not going to be regular. However, your P wave still should be nice and round and upright, and your QRS should look normal, okay? But we're just definitely going to see a pause. So here we go with this one. You see a P, a QRS, and a T, a P, a QRS, and a T, a P, a QRS, and a T, and there's probably a P wave right here, that next little blip, but then you see this little quivery line, and then a normal P, QRS, T, okay? This is changing with someone's inspiration or expiration. So it's just a little bit of a pause here. Now, with this one here, you can see that there's a little bit of a wider spot, and these two, if I counted them out, we can't see the little tiny squares within each of these big boxes on this particular drawing. But if we were to measure them out, they're probably going to be, they look to the naked eye without counting, they look to be pretty normal from here to here and here to here. And then it starts to get a little bit more narrow or a little bit quicker. So again, this is just changing with the patient's breathing, okay? But you still see a P, it's very flat compared to some of those that we've seen here in this example. This one, it's a little more peaked and noticeable, but QRST. So it's all really looking normal. It's just that you're having these, this might be their normal, and then this, is, speeding up a little bit, or this could be their normal, and this is the slowing down period. Most likely that's the case. With inspiration, it's a little bit quicker, and then they have, this was probably from the previous breathing cycle. So that's just something that can happen. It's just a little bit of an absence, but when there's not that pause or not that absence, everything looks normal and beautiful. It would measure out appropriately. Okay?
I have a quick question.
Yes.
Would you always see it speed up during inspiration? Is that usually the pattern?
I would say so. Yeah, I would say so. And then you're going to see at the end of the inspiration, this little pause and the expiration. But again, it all looks normal. But if you measured it out, because you do have these pauses or these absences, the P to P and the R to R will end up being irregular. Okay? Because although it might be normal here, this PR, and this PR and this PR, you can't say that it's normal because you get this pause or this absence. So the P to P and the R to R is going to be abnormal because then you think about your P to P here and this P to this P. Well, there's no R here because there's that pause. So you got to say that your P to P and your R to R are irregular, but you do have those nice round upright QRSs that measure normally. And you think about when you breathe in and then before you exhale, you almost do. I mean, we really don't think about breathing, right? It just happens naturally for us, thank God. We don't have to think about taking a breath in and blowing it out every time. We get nothing else done other than thinking about keeping our breathing going. But when you think about how you breathe, if you pay attention to your breathing at some point, it makes sense that it's, definitely more of a normal rate here, and then you see the pause right before the expiration. Okay?
When you're calculating the rate with arrhythmias, would you just do how you normally do it?
Yep. And you're going to find again that when you measure the QRS complex, you should have a correct measurement. It should not be abnormal. Excuse me. But when you're trying to measure the PR interval, like a P to P or an R to R, it's going to be abnormal because, again, you're going to have this pause. Okay?
Miss Stephen, what did you say caused this? Just like abnormalities?
Well, so on this particular one here, it's just like a change. People can change with their breathing most times, between inspiration and expiratory. Somebody keeps getting kicked out of the waiting room, it looks like here. There we go. Sorry about that. Yeah, so again, it's going to start in the SA node. So we know that's up in the atria, but the impulses for a sinus arrhythmia, they're not regular. And so they oftentimes change with the breathing. So because you have a P wave, you know that you've got it starting up in the atria. But it's just not. Hello?
Oh, sorry, Miss Stephen.
Yes.
Then what would be the treatment for this, or is it just monitor?
Yes, exactly. Yep.
Okay.
Yep. Okay. Now, the next two that we're going to look at here are referred to as sinus arrest and sinus exit blocks. Okay. So you see here on your slide, in arrest, the SA node does not initiate the impulse. It will have a pause of greater than 2 when you measure it out. It will measure greater than 2 previous cycles of the underlying rhythm. And I'm going to show you some examples. It's going to make sense, I promise. When you have a sinus exit, the SA node fires, but the conduction doesn't move through the atria, excuse me, like it should. So there's not going to be any atrial or ventricular depolarization. Well, we know the atrial depolarization looks like a P wave, and a ventricular depolarization is a QRS, right? So with an exit, we're probably not going to see that if it says that there's no depolarization happening. So with the exit, the difference between the exit and the arrest will be measured greater than 2 of the previous cycles of the underlying rhythm, and the exit's going to be equal to 2 previous cycles of the underlying rhythm. Okay? But with both, you're going to see that pause on the monitor, okay? With no P, no QRS. And again, the difference is going to be the length of time that it occurs, and it's going to tell you whether it's an arrest or an exit. So, here are your examples, okay? This top one, if we counted it out, let's just count the big lines here. So let's say 1, 2, 3, 4, 5, about maybe just shy of 5 big boxes. Let's count between here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20 roughly, okay? So is this one going to be an arrest or is it going to be exit?
Arrest.
Arrest, because this pause where I see no P's, no QRSs, I don't see any atrial or ventricular depolarization happening, this measurement is greater than 2 previous cycles. Everybody understand that before I move on?
So
Okay.
does that mean that that would be greater than 5 or greater than 10?
So it's greater than 2 previous cycles. So if we measured from, let's say, this is a cycle here from the P to the end of the T and the P to the end of the T, you could count this whole thing out if you wanted to. So that's slightly before that box. So 1, 2, 3, 4, 5, 6, 7, 8-ish, 8.5-ish, but still we counted 20, and this is roughly, let's just say 6, I don't know, let's just say it's, I'm going to say 8. So twice 8 would be 16, and this is greater than that. We counted that out was roughly 20 without doing it real precise. So it's greater than twice the 2 previous cycles. Okay.
So
Okay.
you start from the P, sorry, to the other P. Is that
Well,
what?
a whole cycle would be from the beginning of the P to the end of the T. That's a whole cycle. So this is 1. Here's the start of the next P, and the T finishes. Okay? So this is a cycle. This is a cycle.
So you
Okay.
don't count in between, sorry, the cycles, or do you? Sorry.
Yeah, when you're counting it out to figure it all out, you're going to start, if you're going to count what 2 previous cycles is, I would start with this P, and I would count all the way through to the second T. Okay? And whatever that is, go ahead.
Just so I understand, so if the distance between that second R to that last R was 16, then we would consider that exit.
If it's equal to, but
Okay.
yes, yeah. Now, this bottom one, I've got it on here for you. It is an exit block because if you count this out and you measure it out, and the little squares within there are hard to see, but that's okay because we know that this part of our graph never changes. It's always going to be 5 wide little squares and 5 tall little squares within each of the darker grid, all the darker boxes. So it's okay that we don't see those tiny squares in there. But if we marched this out and counted it out, we would see that this pause here is equal to 2 previous cycles. Okay? I'll see if I have more examples to show you later. But that's really the only difference. It's still a pause. You don't see any atrial or ventricular depolarization during this pause, do we? Now, this one's drawn perfectly flat. This one, you see there's a little bit of a quiver in there, but there is no P wave. There's no QRS wave. So there's no ventricular or atrial depolarization happening. That's the difference.
Ms. Stephen,
Yes.
where do you begin counting in the pause? Is it at the end of the T wave?
Yes. When you've got that isoelectric line we talked about yesterday, and that's kind of like your starting point. So when that T comes down, I would say right in here somewhere, and you would start counting again. Okay?
What would be the leeway that you would give? Like, is it like half of like one of the little boxes in there?
I would say that if we ask you this on a test, it's going to be pretty obvious for measurement purposes. It's not going to be like so microscopic that, again, we're not trying to do any like gotcha kind of questions or anything like that. I'm so sorry. I'm struggling with this change in the weather from snow to warm and I don't know, spring or whatever it is, and back to winter. So yeah, it's going to be obvious. It's not going to be anything so microscopic. Remember yesterday we talked about a lot of things, if sometimes you might get a half of one of the tiny little squares, but it's when you get beyond, greater than one little square is when we start looking into things being whether they're regular or irregular and that kind of stuff. So we're not going to have anything that's going to be like so microscopic that you can't figure it out. Okay. All right. But again, there's nothing happening. You don't see any P's, any QRSs, so there's no atrial or ventricular depolarization happening. Okay, so we learned the basics yesterday. We learned our only normal rhythm, which is normal sinus rhythm. And now we have gone through we've gone through the sinus brady, sinus tach, and we've looked at sinus arrhythmias, meaning absence of, including sinus block exit and sinus arrest. So now we're going to move into atrial dysrhythmias. So when you're studying, if you think about this in chunks or in buckets, what we've done so far is talked about our only normal rhythm, and then the sinus brady, sinus tach, sinus arrhythmia, which is the exit or the arrest block. And then if you think about your next chunk or your next bucket as being the atrial dysrhythmias, and then we're going to talk about heart blocks, and then we're going to talk about ventricular dysrhythmias. So it might help you. If it does, great. And if you want to study a different way, that's fine too. But I think if you try to think about them in buckets or categories like that, it's going to help you because, again, the atrial dysrhythmias, it's something wrong with the atria, right? So we're going to probably see something wonky with our P waves. And when we start talking about ventricular dysrhythmias later this afternoon, we're going to see something wonky with our QRSs, right? Because the ventricles are represented by the QRS. So if it helps you to break it apart in nuggets or buckets like that when you're studying, it's something for you to consider. Because overall, 6 hours of lecture about EKGs, it can be overwhelming and you can start to get yourself a little anxious and confused. I was a student one time too, so I understand. I've been there. I haven't forgotten that. It's been a long time ago, but I haven't forgotten that. So I'm trying to help you, and if that helps you trying to break it apart into buckets or chunks, I think, great, go with it. Okay, so now we're moving into atrial dysrhythmia. Again, it means that there's something happening not quite so right. So, atrial dysrhythmia, most often caused by increased automaticity in the right and left atria, or it could be both. And these are the ones we're going to look at. PACs, SVT and PAT, which really are kind of used interchangeably, atrial flutter, and atrial fibrillation. Now, so what's happening when you get into atrial dysrhythmias is that you have some increased electrical activity. As I said, the automaticity, meaning it generates its own electrical activity. Remember, our myocardial cells can do that for us. With atrial dysrhythmias, if the SA node fails to fire, another site in the atria can start that electrical impulse. It's like some sort of irritable foci. If somebody maybe had some sort of heart surgery, it could be scar tissue that's there. That could be the irritable foci, and that could be what is actually starting the electrical impulse instead of the SA node. The impulse is going to travel to the AV node, and then to the His, and then to the branches, and then to the Purkinje fibers. So what's going to happen is the ventricles are going to depolarize correctly, and so you're going to have a normal QRS, okay? Because again, our problems with the atria. All right. So the first thing I said we were going to look at is our premature atrial contractions. You can read your slide there. Again, the underlying rhythm is going to be regular, usually normal sinus rhythm, but the pre-atrial contraction is going to cause irregularity. So the P wave is going to come early, and it may not be small and beautiful and upright and rounded like we've seen in some of our examples, okay? This could be followed by a compensatory or a non-compensatory pause, okay? We'll talk about that a little bit more here in a little bit. But basically what happens is if you have a compensatory, meaning it compensates, the R in the complex before the PAC to the R in the complex after the PAC are equal to 2 times the length of the R to R in the underlying rhythm. Okay? And I'll say that again, and we'll look at it. We'll look at some examples. I've got examples embedded after each of these definitions. Okay? So in compensatory, the R in the complex before the PAC to the R in the complex after the PAC is going to measure out to be 2 times the R to R in the underlying rhythm. Okay? And then if it's non-compensatory, the R in the complex before the PAC to the R in the complex after the PAC is going to be less than 2 times the R to R of the underlying rhythm. Okay? And this is in your book if you want to look at it a little bit more. I'm going to tell you some causes and treatments and stuff here, and then we're going to look at an example. Okay? So your causes and treatments are there for you on the slide. Some other causes you might think about: pain, fever, anxiety, exercise, medication. Who drinks caffeine? I can guarantee you're all having a PAC at some time or another. Okay? And probably the more you drink, probably the more you're going to have. I drink my fair share of coffee. I'll be totally transparent. But what really scares me, and I have 2 grown sons, but my youngest one, at different periods of his life, has been really addicted to energy drinks. And I know some of you are too, because I've had you in clinical. And what do I say about it? It scares me, because they seem to have quite the amped up caffeine than, a cup of coffee. So if you drink caffeine, I can guarantee that you probably have some PACs from time to time. Okay? So those are some other reasons that you might have them. And a PAC alone by itself, it really isn't too serious, but it may lead to some paroxysmal atrial tachycardia if you have too many of them. And we're going to look at that dysrhythmia here in a little bit. Okay, but let's focus on this for right now. Okay, so let me move on to my next slide here. All right, so we see here in the top, they've got it even outlined for us. So this is a P wave, but it's coming in on the previous T. Can you guys see below that line how the T wave hasn't quite finished yet? And that P's jumping in. Same thing here. The T wave is still up, and it hasn't come back down to the isoelectric line yet. And that P wave is jumping in. See how this T wave comes back down to the isoelectric line? So if we draw, I'll try to draw with my mouse backwards. That T wave should be coming back down around in here somewhere. But before it can, that P wave is getting anxious and it's jumping in. Now if I look here, this looks normal. P, Q, R, S, T. Pause. P, Q, R, S, T. Pause. P, Q, R, S, T. Pause. See how that looks normal through there? We don't have enough of this previous strip to do the calculation and calculate that out. But does everybody see how this P is jumping in on the T wave territory? Okay.
Yes, Ms. Stevens,
Okay.
excuse me.
Yeah.
I have a question. So I was trying to figure out how to the non-compensatory. I think I might be saying that wrong, but where does that come in when looking at this?
Yeah, so with this particular one, we can't see because we don't have enough to the left of this strip. But what you would have to do is you would have to look at, with the compensatory and non-compensatory, you look at the R in the complex before, well, we might be able to do it with this one. I would like to have a couple more over here. But what you're doing is you're looking at the R in the complex before the PAC. So we could look at just this one. I would like to have more. But you would look at the R in the complex before the PAC. So this is the R prior to the PAC, correct? To the R in the complex after the PAC. And it would have to be equal to 2 times the R to R of the underlying rhythm. Oh, somebody got kicked out. Hold on. Okay. That should work. So I would like to have more over here, but if we counted like the R to R here, that's what you're doing. You're figuring out, this is my normal rhythm, right? This looks normal to me. Everything looks nice. We already looked at P, Q, R, S, T, P, Q, R, S, T, P, Q, R, S, T, P, Q, R, S, there's the rest of our T. If I figured out what my R to R measurement is here, In compensatory, you would be measuring the R in the complex before the PAC to the R in the complex after the PAC, okay? And that would be equal to 2 times the R to R of the underlying rhythm. But this one's kind of hard to figure out because just of the way the strip is printed. I would have liked to have had these like right in the middle so I could see some before and some after. So I'll see if I can find more examples for you. But that's what you're measuring. You're figuring out what the measurement is from the normal underlying rhythm of the R to R. And if it's going to be compensatory, it's going to be equal to 2 times the R to R of the underlying rhythm. So if you figure out what this R to this R is times 2, okay, compensatory would be that measurement twice, okay? Here's another example. This one's got a little tooth kind of hanging up there, but you see it jumped in early on the T wave. Let's look at some of the normal underlying rhythm here. P, QRS, T, pause, P, QRS, T, pause, P, QRS, T, okay? This one we know does not look normal. It's jumping in early on the T wave. So you're going to be looking for, something like this, something like this. The T has not had time to come back down to its isoelectric line and have a normal pause before the next P wave. The P is jumping in early, okay? But if you see my QRSs look normal, okay? So again, because its first name is atrial, we know it's a problem with the atria, and the atria is represented by the P wave. So you're looking for some abnormality with the P wave, and we see it here and here, where it's jumping in early. Okay?
And
yes.
would we be doing anything for this, and would the patient be feeling anything for this?
Sometimes, depending how many you have, and again, people that drink a lot of caffeine, or some of those other things, if they're exercising, if they have a fever, they might feel like a little bit of, sometimes people say they feel a little bit of fluttering, pretty high up, like maybe more toward their throat. I have them all the time. I feel them all the time. And, unless they're symptomatic, unless they're, they're having, some sort of ill effects from it, no, you really don't do anything. They're just going to be brief and they're going to move on. Now, again, if it is a lot of them, it could end up being going into paroxysmal atrial tachycardia, which we're going to talk about in just a minute. But a PVC here or there all by itself, alone, it's not usually too serious. So continue to monitor. Okay.
The non-compensatory and the compensatory, is there a difference? Like, is one worse than the other, or is it just the measurement?
Really, I mean, your causes, your treatments, and monitoring the patients all going to be fairly similar. The measurement is what determines if it's compensatory or non-compensatory. Again, if the patient is asymptomatic, monitor them. If they're symptomatic, you want to withdraw whatever stimulus it is, stop exercising, pull back on the caffeine intake, that kind of stuff. If it becomes too much, as you saw on your slide there, go back. If it becomes too much there, withdraw the stimuli, and you could treat with a beta blocker, because we know that beta blocker, at least by this point, we should know beta blockers slow down our heart rate, right? People think, oh, well, they're for blood pressure. Well, they are, but they're going to affect your heart rate too. So as long as they're not symptomatic, then you're going to continue to monitor. But if they're starting to have issues, obviously stop exercising, reduce caffeine intake, things of that sort. Okay? All right. Let's move on. I talked about if you have too many PACs, it could lead to ill effects such as paroxysmal atrial tachycardia or supraventricular tachycardia. Okay. Supraventricular just means above the ventricles, okay? Paroxysmal atrial tachycardia. I'm gonna get somebody in here. Hold on a second. Okay. So supra just means above. So supraventricular, above the ventricles, and paroxysmal atrial tachycardia, really they're used interchangeably. Paroxysmal really just means that it comes on or leaves suddenly. And a lot of times with the supraventricular tachycardia, you're going to see that it sticks around a little bit longer, that it's more sustained, okay? But really, they're both coming from the atria. So don't let that confuse you. Don't let that trip you up. With this, typically, you see their rate greater than 150. The P waves are present, but they're going to be hard to see. So you're probably not going to be able to measure that PR interval. Your QRS is going to look normal, but it's going to be really fast, okay? We knew that sinus tachycardia was greater than 100, but with sinus tachycardia, we could clearly see the P wave, the QRS, and the T, couldn't we? Well, with this, it's not going to be that obvious, and we're not going to be able to measure that PR. We're not going to be able to see the clearly defined P waves, although they might be present. If you happen to be able to see a P wave and measure a PR, it's typically going to be 0.12 to 0.20. But a lot of times what you're going to have is the P wave is going to be hidden in the previous T wave, okay? Now, again, the paroxysmal atrial tachycardia happening in the atria, you're going to a lot of times see where it starts off from the underlying rhythm. So you're going to have the patient going along normal, you're seeing a clearly defined rhythm, and then suddenly this kicks in. With the SVT, if you're just looking at a 6-second strip, a lot of times you won't be able to see where it starts and stops because it just runs. It's sustained. It runs a lot longer, okay? But really, they're both happening above the ventricles in the atria, okay? Typically, this is going to be a rate of greater than 150. I'm going to say somewhere between 160 and 250. So pretty fast. And you can't sustain that for very long without having some ill effects. Okay? This patient's going to get sick in a hurry. Okay? All right. So here are some causes and some treatments. You may see this with or without an underlying cause. And it's just really something irritable in the atria is making this happen. All right, so here, looking at these two examples, it's hard to differentiate a true P wave, but you can see here in this bottom example, see where the T is coming up and it comes down, and then there's a slight little bump. That's your next P wave. So remember how I said the P wave can invade on the previous T? And then here we have a normal QRS. Because again, the problem is coming from the atria. So the QRS should look normal. And it does in both examples. Okay? In this example up here, QRS, I really don't see a P wave. Here's my T. Again, I don't see a P wave. A QRS, a T, I don't see a P wave. And how do I know that? Because I told you yesterday that you always have a T wave because the ventricles always have to depolarize. And the QRS, the depolarization is the QRS. And because this is normal, I have to have this repolarization in the T wave. QRS is normal. I have to let it repolarize, rest, recover, refill. QRS is normal. T wave, rest, recover, refill. All this is normal, okay, for the QRS and the T. It's the P's that I'm not seeing, and it is super fast, okay? Here, I get to my underlying rhythm. This looks pretty normal. Here's a nice P wave, a QRS, a T, a P, a QRS, a T, a P, a QRS, a T, P, QRS, T, P, QRS. We can't see the rest. But if we wanted to calculate this out, just on this 3 seconds here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 10 and a half. Let's just say 10 in 3 seconds. So if this was sustained, we could assume, let's say that the next 3 seconds would be also 10. So 20, times 6, it's going to be 120. Now, again, because it's not a full second strip, we truly can't calculate out the actual rate because that only gives us 120. And we said that this is typically greater than 150. So we would have to have the full thing to really calculate it out accurately. But you can see by counting it that in this 3 seconds is much faster than in this 3 seconds, right?
Isn't it times 10 for this 6 second?
Oh, yes. I'm sorry. I said that wrong. Thank you. I said that wrong. Whew, maybe I should drink more coffee. Yes, you're exactly right. I said that incorrectly. Yes, you take a 6 second strip times 10, but we don't have the same rhythm in a full 6 second strip. So it's really kind of hard to calculate out and say for sure. On this one, we do have it. Now, I want to point out something on this bottom strip here before we go counting the rate. Remember I told you there's never going to be any difference in the number of the little squares within each big box. So if you look at this strip, it's 5 across and 5 high little squares in each big box. Same as this strip and every other strip we looked. But when you look at the manufacturer of this particular strip, the hash marks on this one are every 3 seconds. If you count out the big boxes on this one, they put a hash mark at every 1 second, but the boxes still measure the same. So if you would get an example like this, you still need to know how many big boxes it takes to equal a 6 second strip. So it would be 5 big boxes equal 1 second, whereas here we've already talked about it, 15 big boxes is 3 seconds. So this manufacturer just has a little hash mark every 1 second. But it doesn't matter. If you see hash marks, you can still figure out, here's 1, 2, 3, 4, 5 big boxes. Okay, I know that that's only 1 second. Here's another 1 second. So here I have 1, 2, 3, 4, 5, 6. I still have a 6 second strip. Don't let those hash marks at the top confuse you. The number of little squares inside each big box still measures the same. It's still going to be the same. It's not going to be like, oh, this one's 8 wide and 8 high versus this one's 5 wide and 5 high. Don't let that confuse you. That's not going to change. Okay, but let's count this one out, okay? So if we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20 times 10 for a 6 second strip is what?
200.
Yeah, 10 times 20 is going to be 200, right? Your heart can't sustain that very long. That is not good. Now, we tend to see little kiddos run at a higher rate, right? But even over a long sustained period of time, they're not going to be able to handle this, right? So anyhow, you could see how it is very fast. It's definitely greater than 150. Our P waves are not discernible. So we know that it is not sinus tach, because in sinus tach, we could clearly see a P, a QRS, and a T for every single cycle. This one we cannot, and it is greater than 150. So it is, it's going to be a paroxysmal or supraventricular tachycardia. Again, supraventricular just meaning above the ventricles, okay? And paroxysmal atrial tachycardia also from the atria. Okay. A lot of times though, with supraventricular, you're going to see the whole 6 second strip just be from start to finish like that. With paroxysmal, you might see where it starts and stops. Okay. And if you're looking just at a 6 second strip, but they're both coming from the atria. They both really, I'm sorry.
You counted that whole strip and then multiplied by 10, but I thought that from one hash mark to the next was 3 seconds, and you're only counting 6 seconds and multiplying by 10.
Okay, so that's what I was just explaining. On this particular manufacturer, they put a bunch of hash marks at the top. But if I count out the big boxes, they have put a hash mark at every 1 second instead of every 3 seconds, whereas this manufacturer has the hash mark at every 3 seconds. I know that because each big box is 0.20, if I count out 1, 2, 3, 4, 5 times 0.20 in this bottom example from hash mark to hash mark, I know that means that it's 1 second, right? 0.20 seconds times 5 is 1 second, correct?
Yeah, okay, I'm sorry. I thought for a
no, that's
second.
okay. So yeah, this manufacturer has a hash mark at every 1 second, and that's what I was explaining, was that you could still figure it out that by counting the big boxes how much the time is. So if I count from here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So from here to here is my 3-second strip. It's just that the manufacturer went ahead and put a mark in at 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6 seconds. But if you know your measurement of your big box, 0.20, and 0.20 times 5 give you 1 second, you can calculate out that from here to here is 3 seconds, just like from here to here is 3 seconds. Because here, 1, 2, 3, 4, 5, this would be 1 second. 1, 2, 3, 4, 5. This would be 2 seconds. 1, 2, 3, 4, 5, 3 seconds, and so on and so forth. Does that help you now?
Yeah, that makes
Okay.
a lot more sense.
Okay. Yeah, this manufacturer, I don't want that to trip you up. This manufacturer just decided to put one in it every 1 second. It still doesn't change the fact that there's always going to be 5 little squares vertically and horizontally inside each bigger box. That's not going to change.
Ms. Teven.
Uh-huh.
So for the bottom one, when we got 200, when we were counting, would we always use that, the 6-second one, I think we multiply it by 10?
Uh-huh.
Will we use for the other one? So I was looking up the 1,500 divided by the number of small boxes. And when I was looking at it, it didn't give 200 on the test. Like, how will we know which calculation to use?
So if you go back to those definitions, if you have a 6-second strip, you should be able to pretty much figure it out.
Because it's regular.
If you know it, yeah. But some of those other definitions of the methods to use, some of them, as you might remember, you have to have a regular rhythm in order to be able to use them. Okay. You've got to find like an R on a black line or a bolded line or something like that. And when we look at this one here, and I look at my R's, this one's after a black line, this one's before a black line, this one's after, this one's before, that one's, so this one's almost directly on. So, you gotta pay attention to the definitions about which, what the requirements are of using a particular calculation method. But again, the quickest, easiest way is to take a 6-second strip if you know for sure that it is a 6-second strip, and multiply by 10. But again, even if you don't have the hash marks, you can yourself, by counting the big boxes or by counting the tiny squares within the big boxes, you can figure out what 6 seconds is. Because again, hash marks or no hash marks, you know that one big box has 5 little squares horizontally. Each little square is 0.04 times 5 within the big square is going to be 0.20. And if I take 0.2 times 5, that's 1 second. And then, so 5 big squares, again, is going to be 1 second. So even if you don't have the hash marks, you can use those other methods by figuring out how many little squares do I have or how many big boxes do I have, and figure out what the timing is. Okay? All right, how am I doing on time? Speak of timing. Oh, it's time for a break. All right. You guys don't be shy about telling me when it's time for me to hush and let you all go get your drinks refreshed and go to the restroom. So it's 9:51. I will see you guys back at 10:01. We're going to try and plow through hopefully the rest of the atrial and get started on the blocks before lunch breaks. I'll see you in 10 minutes.
Miss Steven, can I ask you a quick question about
Sure.
when you were talking about the PAC, you said that the compensatory and non-compensatory was described in the book. Where exactly does it talk about that? I couldn't find it in like the paragraph about it, but like I was wondering if maybe there's like a different chapter with just like an insert or something about it.
Yeah, let me grab my book here. 1 second.
Okay.
It's page 764.
Okay, sorry about that. I had to grab my book. So I am using the Lewis 11th edition. You guys might have the 10th edition based off when you started the program. I'm not sure. They're not all that different. As far as actual talking about the PACs, that's in the 11th edition, it's on page 762. Now, it doesn't really go into compensatory and non-compensatory so much right there on that page. But again, in order to prepare my lectures, I use supplemental resources too. And I showed you guys yesterday, the book that I have, you don't have to have, you can look this stuff up online. You could use any kind of really cardiac dysrhythmia book. But the book that I have that I showed you yesterday, in here, it describes it really, really well. As far as the difference between a non-compensatory pause and a compensatory pause. So you can look at some optional resources if you need a little bit more clarification or understanding of that, even online resources. But again, everything that you need to really have comes from the lecture and from the Lewis. And the 10th edition and 11th edition are very, there's not really enough difference in them to get excited about. So I wouldn't get super duper hung up on, if you don't have the EKG book, if you have the 10th edition versus 11th edition, it's fine. It's fine. You have everything in that textbook that you really need to know and supplement it with your lectures that we're providing to you. But if you want more clarification, more fine detail, you can always look online or look in an EKG dysrhythmia book that might give it a little bit more detail. Because I don't, other than the PACs themselves, I don't see a lot right there on page 762 in the Lewis, specifically regarding that. Okay. All right. So we're going to go on through here now, atrial flutter, and get you out hopefully on time for lunch. If it gets to be 10:50, somebody holler at me, okay? All right. So, oh, see here. Okay. Somebody in the chat's just saying they have that book. If anybody wants, they'll send the pictures to them of that page. Okay. Thank you. So let's look at atrial flutter now. Again, the first name is atrial, so you know that it's coming from the atria. The focus is coming from the atrial. And the last name is flutter because of the characteristics of the flutter waves, a sawtooth wave, a sawtooth wave. Sometimes you'll hear people refer to them as an F wave. So what's happening here is the atria is beating too quickly, if you want to say that. There's a problem with the electrical system, and you truly just cannot see a P wave, but you will see these little flutter or little F waves, we sometimes call them. A normal P is not produced. You're going to have and again, I'll show you an example after we get through these definitions. You're going to have a downward stroke or a deflection, which is going to be representing the atrial depolarization. Then you're going to have an upward stroke, which is going to be atrial repolarization, which normally we do not see because it's hidden in the QRS complex. The AV, remember, that sits at the bottom of the atria, it is going to slow the impulse down so that the ventricles can depolarize at a normal pace. We want that to be a normal rate. And because the atria and the SA node isn't conducting like it should to the ventricles, you're not going to have that normal P wave, but there's going to be, because it's conducting, it's fast, you're going to have a lot more F waves than you are QRS complexes. Okay, so no normal looking P, but you're going to have in place of that this F wave, this flutter wave. Come on, there we go. Okay, so causes and treatments here on your slide. Again, it's just gonna, the atrial part is not gonna be normal. It's gonna be very fast. For treatments, if you need to, you can give the patient oxygen if they're hypoxic. Because again, the QRS, the ventricles, it's doing what it's supposed to. So we can give them oxygen, and the ventricles are hopefully going to just, perfuse that out to the rest of the body. So that will help. Synchronized cardioversion for this patient with serious symptoms, they can be converted with lower energy levels. And then if they have serious signs and symptoms, such as like hypotension, signs of shock, heart failure, you want to respond accordingly based off of, whatever it might be that they're experiencing. But if the ventricular response with atrial flutter is less than 60, then it's considered an SVR, or a slow ventricular response, okay? If the ventricular response, meaning how many QRSs do we have, is greater than 101, then it's considered an RVR, or a rapid ventricular response. So you would treat that patient with synchronized cardioversion. You might give them diltiazem, beta blockers, something like that. Again, we know beta blockers work on our blood pressure, but they really work to slow down our heart rate. Now, the faster the ventricular rate, the QRSs, how many QRSs do we have, the more symptomatic a patient is going to be. And again, if that happens and we see so many QRSs, we know QRSs are our ventricles contracting. If they're contracting so fast, what's going to happen?
You're not going to get enough blood to pump through the body.
Right, because the ventricles they're beating faster than they can actually fill, right? So if it happens to be a fast ventricular rate, a rapid ventricular rate, an RVR, you might hear somebody talk about the patient has atrial flutter with RVR. That means that the ventricles are beating fast, greater than 101. The faster they beat, the less time they have to fill, the less oxygen-rich blood being pushed out to the body, the more symptomatic your patient's going to be, okay? So in that case, if I give my patient a lot of oxygen, is it really going to help them? Probably not. Yeah. Probably not. Okay, let's look at an example. Okay, so here, the QRSs tend to look pretty normal, don't they? Same thing down here. They look fairly normal. But I don't really have any identifiable P wave. Instead, I have this up, down, 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 up, down. You know, I mean, and down here. So it's referred to a lot of times as a flutter wave or an F wave. You'll hear it called sawtooth. But it just does not look normal. But my QRSs look normal. Okay? So it's a problem because I don't have clearly identifiable P waves. It's a problem with my atria. So it's got to be first name, atrial, and then these are my flutters. So atrial, flutter. Okay? All right. Next one, definition. First name is atrial. So it has to come from the atria. The last name you can read there, fibrillation. Again, no discernible P waves, okay? So the atria in this sense are kind of just like twitching or quivering and you know, shaking. They're not doing what, they're not squeezing. They're not doing what they need to do. They're just kind of quivering. So they're beating out of sequence with the ventricles. So I'm sorry for those of you that have had me in 101 or 151 that you're going to hear the story again about the ketchup bottle. So what happens is you have a ketchup bottle and it's nice and full, and when you squeeze it, you just got it from the grocery store, you squeeze it, it just nice big gush of ketchup and it covers your french fries, right? Well, that's really what we want to happen with our heart when the ventricles squeeze. We want this nice big gush. Well, somebody puts the ketchup bottle back into, your little brother or something puts the ketchup bottle back into the refrigerator, and it's like you pull it out and it's got like this much left in it. It's kind of, you got to like bang on the counter to get it down there, and when you squeeze it, it just splatters. Well, that's not giving us a nice big gush of blood, and we'll talk about that when we get to the ventricular dysrhythmias. But I can use that analogy here too with the atrial dysrhythmias, because when the blood moves from the atria to the ventricle, we want it to be a nice big gush. We don't want it to just be a little splatter or a little drip, drip, drip. We want it to be a nice big gush when it's going from the atria to the ventricle, and the ventricles, of course, out to the body. So I think about it like that ketchup bottle that's almost empty, and that we're not getting that nice big gush of blood from the atria going down into the ventricles. Instead, the atria are just sitting there and they're kind of quivering or shaking. And so we're maybe getting this little drip, 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 drip of blood going from the atria down into the ventricles. Okay? So again, it's because it's not contracting. It's not depolarizing normally. It's just doing a little more quivering. Okay. With atrial fibrillation, you can have a rate. You see here, atrial rate is greater than 350, but it's not measurable. It's just, you can't. We're going to look at an example, but oftentimes you can have a rate up to 650. That is scary, okay? The hallmark of atrial fibrillation is that it is irregularly irregular. So it's irregular, but it's not irregular at the same consistencies, at the same, intervals. So it's irregularly irregular. So it can come on and look like this, and then it can look something different. So it's irregularly irregular. So with this, the patient's probably going to have some symptoms such as like heart palpitations, shortness of breath. They might have some weakness. So not good, not good. So you see here your causes and your treatments. With this, the patient's going to have decreased cardiac due to a decreased blood flow coming from the atria to the ventricles again, okay? The problems in the atria is a decreased blood, not a nice big depolarization by the atria at all, more of a dripping or a splattering of blood going from the atria into the ventricles. So overall, you're gonna have decreased cardiac output. It could be as much as 25%. So that's not good for our patients. Other causes that aren't listed here that you might consider, they could have diabetes that could cause this. They could have valve disease. They might have some other symptoms such as mentioned shortness of breath and a little bit ago, but they might also be like dizzy, chest pain, palpitations, fatigue. Think about how tired you get if you have just like a really bad bronchitis or something like that. It wears you down. You're not moving oxygen like you should be. So with a heart problem, it's going to be even greater. So you might see those things. Additional treatments that you might see for these patients, really, it's going to depend on their overall health. What other kind of comorbidities do they have going on, and how symptomatic are they? It's also going to be dependent upon what their ventricular rate is and how long is this rhythm lasting, the duration of the atrial fibrillation rhythm. Okay. Now, this causes some real concern because, again, the atria is quivering. So I like to use the word gelatinous. I really don't know if it's a word in the dictionary or not, but I use it a lot. So the blood, because it's not draining out. What happens? Has anybody seen blood on the floor? What happens? Or on the countertop? What happens if you got a pool of blood there? What happens to it in a short time?
It coagulates.
It coagulates, right? Yeah, it gets like gelatinous. That's why I call it jello, gelatinous. So it's going to clot. So that can happen at the basement or in the bottom of the atria. That blood's just not squeezing out like it's supposed to. So it's sitting there and it's kind of getting, you know, clotted or thicker, gelatinous. So that is scary because if this patient has to have cardioversion, what's going to happen when we shock them?
You could dislodge the clot.
Yeah, we're going to send it to the lung, their brain, who knows where, right? Bad business. So if a patient has to be cardioverted, we need to make sure that we give them anticoagulants. And typically it's going to be about 48 hours in advance. We want to make sure that blood all gets thinned down. And that way, when we do apply that cardioversion, that electrical shock, it's not forcing that out and sending that clot somewhere else on the body. Now, what the physician might do is might order the patient for a TEE first, which is a transesophageal echocardiogram. And that's going to first check to see if there are any clots remaining in the atria. Because again, we don't want to shock them, cardiovert them, and send those clots out somewhere else. So they might order that too. And basically how that goes is they go through the esophagus, through the mouth, through the esophagus, and they can look at that, and they can look at those atria that way. Basically kind of like a ultrasound, if you will, an internal ultrasound. Okay. So
what what is this called again? Sorry.
It's called a TEE, or a transesophageal echocardiogram. Sorry, my dog was crying. She had to be in here, and now she's like up under my chair. I'm afraid I'm going to roll over her. She's a mama's girl. So they may do that just to ensure that the anticoagulation therapy has done its job and we don't have a bunch of clots and gelatinous, my word, blood sitting there at the bottom of the atria before they do the cardioversion. Okay? All right, so here's an example of that. So the QRSs, they tend to look pretty normal again, don't they? Again, here we have the manufacturer that has given us a hash mark at every 1 second. So don't let that confuse you, because you can still figure it out by looking at the number of boxes. But there is no way that you could count a rate here, is there? The P's, I mean, you can't really even identify a P. It's just not discernible. You can't figure that out. Okay, so that's different from, let's look back at the flutter real quick. Look at that. See how the QRSs still look normal? But between the QRSs, it's more of that flutter or a sawtooth, versus here, it's more of a quivery line. Everybody see that difference? QRSs still look normal. They would measure normal for me. Okay? So that's an easy way to look at the difference between the two.
When you're giving us the information about like a 350 atrial rate, we're never going to have to calculate that out, will we?
You can't count it, really. I mean, you can't, because you can't identify the P waves. So there's no way to do that. You might know that that is something about atrial fibrillation, that it would be greater than 350, but there's no way you can count that. What you're looking at is, you know that my QRSs are normal, and when you measure them out, like how wide are they? You go back to the very beginning when we talked about how wide our PR should be, how wide our QRS should be, you would be able to see that. But then can you identify a P wave? And then you're like, okay, so there's something wrong with the atria. So I know my first name is atrial. And then I'm looking to see, is it fibrillation or flutter? And this looks like fibrillation to me, because it's more of just that quivering. Again, think about those atria just quivering, okay? Whereas with the flutter, you're seeing more of that. Okay?
And Miss Steven,
Yes.
you can't really see a T wave either, can you? Or can you?
Not really, but we know because the QRS was normal, our ventricles depolarized like they're supposed to, so we have to have a T wave. So there's a T in here somewhere. I mean, that might be a T. It's tiny. That's probably a T. That's probably a T. A T.
Yeah.
But yeah, we know that it has to happen because the QRS, the ventricles clearly depolarized, so we know that they have to repolarize. But it's a good question.
Gotcha.
Okay. All right, now, when I talked earlier about nuggets or buckets, we're moving into our next nugget, which is going to be blocks, okay? So, first degree block, we're going to talk about first degree, second degree has type 1 and type 2, and we're going to talk about third degree, okay? So, first degree, you have a prolonged conduction, if I could talk, from the atria to the AV node or the AV junction sitting on top of the bundle of His, okay? So the SA impulse is conducted, but the length of the conduction to the AV node from the top of the atria where the SA node is to the bottom of the atria where the AV node is prolonged, okay? So we're gonna have a longer PR interval. QRS is going to look perfectly normal. Okay? Again, think about what the definition is. And the definition of first degree is the PR is greater than 0.20 and my QRS is normal. We're going to look at an example again. Here's your causes and your treatments. This patient normally, you're not going to have to intervene. You're going to continue to monitor them. And that's important because it could be a precursor to a more serious event, okay? So continue to monitor them. Typically, you don't have to do any kind of treatment, okay? And if you can figure out what the underlying cause is, of course you want to treat the underlying cause. So if we know they're experiencing an MI or they have hyperthyroidism, they might get a beta blocker. A lot of times I know some of you in my clinical would have a patient that did not have high blood pressure, but they had hyperthyroidism, and we had to talk about that. Like, okay, but why are they taking a beta blocker? Help me understand. Well, we again know that beta blockers work on our heart rate, just like they work on our blood pressure. And so you might treat the underlying cause, but otherwise continue to monitor this patient. Okay, here's our example. Excuse me. So how long is my PR interval supposed to be? Who remembers way back to the beginning of yesterday?
0.12 to 0.2.
Okay. So 0.12 would be how many tiny squares?
3.
3, because each tiny square is 0.04, right? So times 3 would give us 0.12. And times 0.04 times 5 would be our 0.2, correct? So when we look at this example they've given us here in the middle, and we were to count out from the beginning of the P to the beginning of the QRS complex, because that's how we measure our PR, I've got one full box, so I know that's 0.2, and then it looks like about another box and a half. So one full box is 0.20, and I've gone beyond that. So my PR from my beginning to my P to my beginning of my QRS complex is how I measure my PR interval. It is elongated. It is prolonged. Okay? And if I look here, let's see. Let's count it about right here. Okay, so that's 4, 5, that's 0.2, 6, 7, almost 8, I would say. Almost 8 little squares, okay? Times my 0.04 would be my 0.32. So it's still greater than 0.20. So it's a longer PR interval. That's it. That is a first degree block. Okay? The time that it is taking to get from the SA node to the AV node is taking longer than it should. That's first degree heart block. Everybody with me? My QRSs are beautiful, aren't they? I love them. Gorgeous. Okay, you can see this is a good example too. You can see how the T waves are a little bit higher and a little bit peaked in this one. And the P waves, they're a little bit bigger. Not every strip is going to look the same. We talked about that yesterday. They're all going to look a little bit different, but you should, if you know your definitions of the different dysrhythmias and you know how to count and do your multiplication, you're going to be able to figure this out. Okay, so just take your time with it. Okay, now, second degree, I told you there are 2 different types. There is a type 1 and a type 2. You've got lots of information there on your slide. But basically, this is an interruption of conduction at or below the AV junction. So the AV sits at the bottom of our atria, remember? So this is an interruption of conduction at or below the AV junction. We're going to talk about these individually. With type 1, well, let me just move on into it. Here we go. So, second degree, type 1, okay? This is occurring within the AV node. It is less serious than second degree, type 2, okay? And the impulse is going to take longer and longer until you have a beat that doesn't make it all the way through the ventricles. Okay, and then that QRS in that case is going to be dropped. So there's a little, this one also is called Winky Bach. So there's a little saying that says longer, longer, longer drop, then you have a Winky Bach. So we're going to see that the PR interval gets a little bit longer each cycle until we have one that doesn't conduct all the way through and the QRS is going to drop. Okay. Now,
can you say that one more time?
Yeah. So what's going to happen is the PR interval is going to get longer each cardiac cycle. So PQRST, PQRST, those are each cycles. So the PR interval that we just measured in type 1, the PR interval from this cycle is going to get longer to the next cycle and longer to the next cycle, and it's going to drop the QRS because it's not going to conduct all the way through because it's taking too long. Every third or fourth beat or so. I'm going to show you an example. Okay, but longer, longer, longer drop. Now you have a Winky Bach. Again, type 2, excuse me, second degree, type 1. And this one is less serious from second degree, type 2. Okay? All right. So, did I go too far? Oh no, I just forgot to turn my page. That's what happened. All right, so again, if they're asymptomatic, you're going to continue to observe, monitor them. And if they're symptomatic, you might have to give them medication, a temporary pacemaker. Lots of causes here for this. Usually it's temporary and patients can do well with it. Other reasons that this might happen, patient might have valvular disease, they might have cardiomyopathy, they might have an increased vagal tone. If someone did carotid massage on them, which we as nurses do not do that, so please do not. Okay. if they're vomiting, if they have hyperkalemia, if they're on some medications like amiodarone, digoxin, DILT, beta blockers, things like that. Those might be some other causes, some other reasons that they experience this. But again, asymptomatic, observe, continue to monitor, and symptomatic, then we might have to treat them. Okay? Now let's look at an example. Okay, so here, if I measured out my PR interval, so the beginning of my P to the beginning of my QRS, and you can actually count it, but if you want to, with this example in particular, it's pretty obvious to the naked eye. From the beginning of this P to the beginning of this QRS, now look at the beginning of this P to the beginning of this QRS. You can kind of tell with the naked eye that that's already longer. Can everybody see how that's longer without even really counting it? And then from this one to here, it's even longer than this one, isn't it? I mean, if you look just without counting, let's just say without counting, this is one full block in, let's say, a half. This one is 1, 2.5. This one is almost a full block, but we'll say 1, 2, 3 full blocks. And then look what happened here. Here's my T. Here's my P. Uh-oh. Because it took a long time to get here. This is not normal even. This is even more abnormal. This is really abnormal. And then here, it just was so slow, it never made it through the ventricles. Then we start all over again. P, QRS, T, and then here, uh-oh, look here. See that? Let's see, that's probably like, 1, 2, 3, and 5 is 8. I'm going to say about 8 tiny squares, so 0.32 maybe. And then this one is, let's say about 3, 5, that's 8, 9, 10, 11, probably about 12 small squares. So again, we're getting longer. That PR interval is getting longer each cycle. Now, you may see this one was longer than it should be, longer even more than drop. So longer, longer, longer drop. You might see that you have longer, 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 longer than drop. It's going to happen probably every third or fourth beat. Okay? It's not always on the fourth one that's missed. Okay?
Miss Stephen?
Yes.
What would the patient be feeling when this happens?
They may be asymptomatic. They may not feel anything at all. Okay? They might feel, you know, a little bit short of breath, dizzy, you know, because again, if our ventricle is dropped, we know our ventricle is responsible for the right side of the heart sending the blood to the lungs to pick up the oxygen, right? And the left side, the left ventricle, is sending that oxygenated blood out to the body. But if that doesn't happen, then we're having a little less perfusion in carrying that oxygen or pushing it out to the rest of the body. So they might have some of just that, you know, general dizziness, lightheadedness, fatigue. Yeah. So don't get hung up on that. It didn't happen on the fourth QRS wasn't dropped. It could be the third one. It could be the fourth one. But if you know your measurements and you know what the normal P to R interval should be, and you can calculate this out, and you can see that this one even gets longer, and then this one's even longer than the previous one, and then suddenly, uh-oh. So I have a second degree type 1, or longer, longer, longer drop. Now I have a winky Bach. Okay? So in type 1, just to recap, in first degree heart block, we have a elongated PR interval. The PR interval is long. In second degree type 1, the PR interval gets longer each cycle until it drops off. Okay? So that's the two that we've covered so far. Now we're going to look at second degree type 2. This is more serious than second degree type 1. Okay? Excuse me. Your block here is occurring at or below the AV node, okay? You're going to see 2 or 3 P waves, for every QRS. Now, when your QRS does not drop off, it's going to look normal. And this is just really going to be intermittent, okay? So again, P's and QRSs are going to measure normal when they occur, but there's going to be more P's than there's QRSs, and this is more serious than a second degree type 1, okay? Here are some of your causes and your treatments. Keep in mind that this can actually deteriorate into a more serious situation. More time. Okay, I got about 10 minutes, looks like. Okay. All right, here is our example. So here I have a P wave, I have a dropped QRS. Here, this looks pretty normal, right? I just said that when we have them, they're going to look and measure pretty normal. So if we counted this out, our PR interval from the P to the beginning of the QRS, and if we measure our QRS, that's 1 square, looks like that's correct. Our T, our P, our QRS, our T, that all looks pretty normal. And then here, I get another P wave, and I dropped my QRS, okay? But
I have a question. So how does this make it different from the first one? Is it because there's more than one drop in the QRS complex? That's what makes it?
Well, you have to look at you'd have to measure out your PR intervals.
Mm-hmm.
And our PR intervals are going to be perfectly normal.
Okay.
Okay. So in first degree heart block, again, we have an elongated PR interval. Second degree type 1, the PR interval gets longer with each cycle until the QRS drops. Second degree type 2, when we have our P's and our QRSs, they all look and measure normally. So that's really a big difference. My PR is going to measure normally, but every so often I'm going to have a P but no QRS. So that is second degree type 2.
Miss Stephen, there's not like a set, like you'll have like 3 QRSs and then a drop, and then 3 QRSs and a drop.
No, it's just intermittent. It's just random. Yeah. Yep. And, you know, looking at this too, my QRS measures correctly. So what that tells me is as long as the QRS is less than 0.12 wide, I know my QRS is normal. So that means that whatever dysrhythmia or whatever problem I'm dealing with came from above the ventricles. Because my ventricular depolarization, my QRS, it measures appropriately. It's less than 0.12. So my problem has come from above. Okay. Okay. Let's try and get through third degree here. And then after lunch, we'll just do the, we'll have to do the dysrhythmias of the ventricles, and we'll have to do a little bit about pacers. And then we'll get into that later in codes and also Dr. Bennett at the end of the semester, but we're going to touch on it today. Excuse me. Okay, third degree heart block. This is considered a complete heart block. What's happening here, you see there's no P waves, okay, that are conducted through to the ventricles. So you're going to see P waves, and you're going to see QRSs, but they're not conducting from the atria to the ventricles. They're really functioning almost as 2 independent systems, okay? So there is a complete block. They're functioning independently of each other. With a third degree, the QRS might be widened. Most times you see that it is. In the PR, it's going to change in length, but it's not progressive like in second degree type 2. Or type 1, excuse me, type 1. Remember how we had the PR wave that went longer, longer, longer drop? Now I have a winky block. So you're going to see the PR with a 3rd degree or a complete block. It's going to change, but it's not going to be progressive from cycle to cycle like it was in 2nd degree type 1. Okay? They're really functioning independently of each other. So let's think about the mail delivery system. Probably shouldn't talk about that because everybody's mail has been really slow the last couple of months. I know people are upset about their Christmas gifts not getting to where they're supposed to be. I got a Christmas card yesterday that was mailed on December 5th. How fun is that? So we're gonna compare this to the mail system. So let's say that the atria is the post office. Well, the mail carrier decides that he's tired of driving way out into the rural counties and delivering mail to the people. You know, there's like 6 farms out in the county, and that's like the rural area. Let's say it's the ventricles. So he just says, forget this. I'm wasting a lot of gas. There's only 6 houses out there. I'm not doing it anymore. So those poor farmers, they're like, but we still need our mail. So they come together in a little town meeting and they decide, well, we'll just create our own post office. So now you have mail delivery going just to the atria and mail delivery just going to the ventricles. You've got 2 independently functioning systems. Okay? One is not going through. It's not conducting through. So you're still going to see the atria, the mail service up there conducting. You're still going to see P waves. And now you're going to see too that the people in the rural farm area, they have created their own mail service. And so you're still going to see the ventricles conducting, but they're independent of each other. Excuse me. Okay. All right. So what are some causes of this? You have those there on your slide. This patient's going to need a pacemaker inserted, okay? They might have some external pacing that happens initially until we can get them to get the pacemaker implanted, but they're not going to be able to continue on without that. So this patient's pretty sick, okay? All right, here's an example. So my QRSs, I can tell you right off the bat, they're wider than 0.12 in this example. And if they're wider than 0.12, we know that the beat came from the ventricles. Because if the beat came from the atria, my QRS should look normal, okay? But it didn't. So you can see here where there's a P wave, a P wave, a P wave, a P wave. There's a P somewhere in here. I don't really identify it, but they say there's a P wave here, another one, another one. So the PR is going to be not really within the right measurement. If I counted out this PR, 1, 2, 3, 4, a little more than 5, I'll say, maybe. And then this one, it's elongated as well. Here I have 2 P's and no QRS, but you see it doesn't go like longer, longer, longer drop, because here it's longer. Here it dropped something. Here it's long. They're saying there's a P in here. There's no QRS. There's another P. There's no QRS. Here's a P, QRS. And if we counted that out, it's probably going to be pretty close to normal. So the difference with the 3rd degree versus the other that we looked at, it's not a progressive elongation of the PR interval. It doesn't go longer, longer, longer drop or anything like that. And it's different from 1st degree because the PRs in 1st degree, they're longer than 0.20, but they're consistently longer. They don't change. Does everybody understand that?
So from what I'm hearing, it's just kind of random because they're just
very,
like doing their own
separate
thing.
systems.
Yeah.
They're working independent of each other. So this mail delivery driver for the atria, he takes his mail 1, 2, 3, 4, 5, 6. He delivers mail 7 days a week. Okay. Out in the rural county, you know, there's only 6 farms out there. So they're like, we don't really need mail every day. So we're just going to take mail 1, 2, 3. We'll take mail 4 times a week. They are functioning completely independent of each other. Okay. And you have to notice that the PR intervals are not progressive like they were when we saw them in second degree type 1, longer drop. We have a lot of QRSs that aren't coming through. But again, it's because they're functioning independently of each other, atria and the ventricles. But we do have random lengths of PR, like PR here. There's no way to measure this one because there's no QRS. This PR is long. This one, I can't really say that I see it, but again, there's no QRS. This one's long, and then here's another P. So they're functioning completely independent of each other.
Is there a reason that this thing's dipping down so far on what like looks like the S wave? Like, why is it going down so far?
It's probably just the lead that they're looking at it from. You remember how we can look at like from AVR, you know, lead 2, lead 3, depending what lead they were looking at it from.
Okay.
Yeah. Yeah.
So it's not always going to dip down like that. Like it could still be going up, you know, like.
You might see it up or down again, depending on what lead you're looking at.
Okay.
But I wouldn't get so concerned with that as I am actually with the width of my QRS. What does it measure? Is it less than 0.12? As well as looking, go back to your steps 1 through 6. Is there a P before every QRS? Well, here's a P, here's a P, here's a P, a P, a P. Yeah, there's a P before every QRS. Is there a QRS after every P? Nope. 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 So I know there's a problem already, right?
Makes sense.
And then I'm looking that my QRS is wider than it's supposed to be. And I see that my PR intervals, I can't measure them because I don't always have a QRS complex following the R. So I notice that it's functioning independently. So I'm not getting as excited about the negative deflection or negative voltage, because we've talked about measuring voltage this way and measuring time this way, as I am with knowing my measurements of what is my normal PR interval supposed to be, what is my normal QRS supposed to be, and going through my steps. Is there a P before every QRS? Is there a QRS after every P? So on and so forth. Okay? There's nothing regular about this. And then you're trying to figure out what your rhythm is. This is a complete or a 3rd degree heart block. Okay? I think you guys are doing fantastic. You're asking excellent questions. It sounds to me like you're getting a good grasp on it. Again, if it helps you to separate things in buckets or nuggets, I think that's a good way to learn. Again, you have to understand and be able to identify and know what your normal measurements are so you know what normal sinus rhythm is. Then learn all the rest of your sinuses, sinus brady, sinus tach. Learn your sinus arrest and your sinus exit, and then move into your bucket of atrials. Premature atrial contractions, atrial fibrillation, atrial flutter, move on into your blocks. 1st degree, 2nd degree, type 1 and type 2, and 3rd degree. Okay, we're going to break here. It's a perfect time to stop for lunch. It's 10 minutes to 11. I will see you guys back at 12 o'clock. We're going to get through dysrhythmias of the ventricles and with pacers. And then this afternoon, your basic EKG test will open up. You can work on it as you can. You can come and go from it. Your weekly math EKG sheet this week will just be math, but starting next week, it should have the EKG rhythms on it as well. And that's the same thing. You can do it as many times as you want from the weekly perspective. You can do those as many times as you want, and you can come and go. You don't have to do it all in one sitting. Like you can open it and walk away and come back. The basic EKG, though, you're going to do once and turn it in. And I would say start working on it sooner than later because it's going to take you some time. And I would really try to give it your best effort because it's only, again, going to help you get those points when you take the test, because there's 10 EKG questions, 10 EKG strips for you to identify on the first test. Okay. But yeah, that basic one, I think it's 60 or 75 questions. I can't remember. So, you know, I would say start working on it and, you know, maybe try to get through, you know, 10 or so a day. And it's due before test 1. Okay. But the weekly one, as Dr. Benetti said yesterday, This first one is not going to have EKG on it. The next ones will have a combination math and EKG, and you can do those as many times as you want. Okay.
For the test EKG strips, will they all look the same, or will they be kind of like how they have been in lecture, where they all kind of look different? Like
yeah, there can be a variety. I will tell you too, when you start doing your basic EKG test that opens up later today, and your weekly EKG, math EKG sheets, there are some of them we understand they're a little more grainy. They're not as clear as we would like for them to be, but you're still going to be able to easily identify what they are. Don't let that stress you out. On the test, they will be very clear. You will not have any issue. I may have said that yesterday. There's a lot of times that people say, I can't figure this out on my weekly math EKG sheet. Do the best that you can do. I still think if you go through the steps, you'll be able to figure it out. But on the test, it's going to be very obvious to you. It's going to be easy. It's to count. It's going to be clear enough for you to count and figure out what your measurements are. So don't let that stress you out. That's a question we get every semester. Are the ones on the test going to be easier to read than this one? Yes, they're going to be more clear. They're not going to be quite as grainy. Okay, well, let's break there. I will see you guys back at 12 o'clock, and we'll push through this, and then you'll be on your way to the next subject, which we start tomorrow. All right, enjoy your lunch.
Thank you.
Thank you.
Thank you.